Okay, doctors, you can start.
Assalamu alaikum wa rahmatullahi wa barakatuh. Distinguished guests and participants, good morning, everybody. It's time each year we commemorate World TB Day on March 24. The date marks the day in 1882 when Dr. Robert Koch announced his discovery of Mycobacterium tuberculosis, the bacillus that causes TB, which opened the way towards diagnosing and curing the disease. It's my pleasure to welcome you all on the occasion of the World Tuberculosis Day. The aim is to raise awareness and understanding about this preventable and curable disease and to address its devastating health, social, and economic impact around the world. Our theme for today is Don't Forget TB. We will be talking about tuberculosis in the COVID-19 era to convey the sense that the world is running out of time to act on the commitments to end TB, as this disease remains one of the top infectious killers in the world, claiming nearly 4,000 lives each day. This is especially critical in the context of the COVID-19 pandemic that has put NTB progress at risk. Without further ado, let us all welcome our speaker for today, Dr. Mohammed Al Saeed, who is an adult infectious disease consultant in PSMMC. Thank you all. Welcome, Dr. Mohammed.
Thank you, Dr. Amel, for your kind introduction and inviting me today to talk about TB. As you mentioned, this year is a special year for TB. We are in the middle of a pandemic that is affecting millions of lives around the world. Lots of people needed medical attention this year because of COVID-19, and many health systems were pressured because of the gush of people going into the system. And led to a collapse of many systems, developed systems, not developing systems around the world. And as we know, TB is a disease of poverty. So most of TB patients affected around the world are in poor areas. So you can imagine how much underdeveloped health systems were pressured about COVID-19. So things I'm going to highlight today in my talk is a little bit of TB history, and then I will talk about World TB Day and End TB campaign. I will also be talking about statistics and epidemiology of TB in the pre-COVID era, and in the post-COVID era, we'll talk about the impact of COVID-19 TB. I have also a little bit of statistics on the things we are doing right here in Prince Sultan Military Medical City. So TB is an ancient disease. Actually, it's traced back to 9,000 years back. Archaeologists found TB in remains of Egyptian mummies. They found evidence of Pott's disease or spinal TB. Also, on the Eastern Mediterranean, there are remnants of mothers and children buried with TB. The earlier written mentions of TB were in India around 3,000 years back, and in China around 2,000 years back. In Islamic scripts, they have also described TB. Ibn Sina has described TB very well, but he didn't know actually what was the cause of TB, but he described the symptoms and the infection control measures should be taken with patients with TB. In medieval Europe, TB was a common disease over there, and the scholars over there thought it was due to devils and demons. Now, as you mentioned, Dr. Amel, in 1882, Dr. Robert Koch, he's a German physician. He was working to find out what was the cause of TB, and he discovered the bacillus on the 24th of March 1882. Dr. Robert Koch worked in several areas of the world, including India. This Sunday in the clinic, I was working with a colleague who was he's from India, and actually Dr. Koch worked in his hospital. But unfortunately, he told me, like in his hospital, they don't have the available facility to diagnose TB these days, and this is really a strange thing. So what about World TB Day? In this day, the date marks the day in 1882 when Dr. Robert Koch, a German physician, announced that he discovered the bacterium that causes TB. And the WHO recognizes this day every year to elaborate about TB and its importance. So each year we commemorate a World Tuberculosis Day on March 24th to raise public awareness about the devastating health and social and economic consequences of TB. The WHO started a campaign in 2015 called NTB, and the tools they are using for this campaign is to raise the awareness about the TB and ways of its transmission. Take prevention procedures against the disease, and renew the political and social commitment to achieve further progress in eradicating the disease and highlighting the efforts to eradicate the tuberculosis. And that's what we're going to do today in this presentation. The indicators of goals. So initially, they had a plan to get 0 cases by 2030. But it seems this will not be achievable with the pandemic coming in the middle. So now their new indicators of goals of achievement were 95% reduction by 2035 in a number of TB deaths compared with 2015, 90% reduction by 2035 in TB incidence rates compared with 2015, and 0 TB affected families facing catastrophic costs due to TB by 2035. So in regards, in 2015, the WHO had an ambitious plan to end TB, as just mentioned. Their targets between 2015 and 2020 were to have a 20% reduction, but they only achieved 9% in the incidence of TB rates. Also, the number of TB deaths, they had a plan to have a 35% reduction, while they only achieved 14% reduction. And in the percentage of people with TB facing catastrophic cost, the target was 0%. But now we have around 49% of the people with TB face catastrophic costs. So going to the statistics, in the pre-COVID era, TB was the most important communicable disease, and I think it's still the most important communicable disease. Each day, nearly 4,000 lives are lost due to TB, and close to 28,000 people fall ill with this preventable and curable disease. This map actually summarizes everything. You can see the high incidence areas of the world. It's in sub-Saharan Africa, it's in Southeast Asia, the areas where it's crowded or poor. And what actually flares up TB is actually another, and especially in sub-Saharan Africa, is another endemic, which is the HIV. In our country and in Europe and North America, we are considered as low incidence TB countries, but with this pandemic, we have to be cautious now, and extra work has to be done to combat TB, especially in our areas, and help others in high endemic areas. Now, the goal was with the initiative from the WHO around 63 million people lives were saved since 2000 from TB. But we still have like 10 million falling into TB in 2019. And the estimation is also similar in 2020. We still don't have the full numbers because of the endemic, but the WHO also estimates 10 million plus cases. And I'll explain in the next few slides. Around 1,400,000 people died from TB in 2019, and around 500,000 or 500,000 had drug-resistant TB. And this is also a second thing that flares up the TB endemic. It's HIV, it's drug resistance, and the third one is poverty. Now, this chart shows, since you can see like with the decrease in incidence of HIV, there will also decrease in incidence in TB. So as I mentioned just earlier, that in sub-Saharan Africa, the most common factor contributing to the flare-up of cases of TB is HIV. And with the control of HIV in those areas, TB cases also went down. And this is that tells you that other endemics, other problems contribute to TB cases. Now, this graph is actually something to be proud of. This is the incidence of TB in Saudi Arabia. It tells you how much, when you invest in your public health system and in your health system in general, you can achieve your goals. In Saudi Arabia, we had around 19 cases per 100,000 in 2000. It dropped to around 9.9 in 2019. And this is all because of the investment in public health. We put manpower, people tracing, we brought the medication for the people, and a proper health system, easy way to access the health system, all contributed to this. Now with the COVID pandemic, we need extra work to keep on this path. So talking about the prevalence of, now we know the incidence, we are considered as a low incidence country, at least pre-COVID era. The prevalence, this is a group of physicians from King Saud University. They were looking into the prevalence of suspected tuberculosis in the Kingdom of Saudi Arabia and looking which areas of Saudi have the most prevalent, or are the most prevalent areas with TB. So they had 3,000 samples from different areas of Saudi Arabia. They found, they looked into conventional cultures, the regular cultures we do for TB, the microscopy and the PCRs. They found around 22% of the cases are distributed between the Eastern Province and Riyadh, to a lesser extent in the in Jeddah area, while the prevalence is lower in the peripheries. I think this is not true, because we know the nature of the Saudi. He prefers to go to bigger centers. So whenever he feels sick, he will go either to Riyadh or to the Eastern Province or to the Jeddah to seek medical advice. So it may be not true. These numbers may be not a true representative of the prevalence in Saudi Arabia. Now, the percentage of TB cases with MDR TB, this is, as I mentioned, this is one of the contributors of a flare-up of TB around the world. When you don't have proper medication, means you cannot control the patients and they keep transmitting the bacteria to other patients. Now, in Saudi Arabia, we are considered also a low incidence area for MDR TB or XDR TB, alhamdulillah. And this is helping us on controlling the disease in our country. While if you go to Asia or Russia, they have a very high prevalence of MDR TB. So this is from our hospital. It's actually a retrospective study looking again for the prevalence of TB by looking into samples, cultures, microscopy, and PCR. It was done this year, or it was published this year. So they looked into samples between 2000 and 2017. The resistance is very low in our hospital. It's around 8%. But what we are interested is the MDR TB resistance, which is it's around 0.01%. And they also looked onto the prevalence of TB in general. As you can see, there was a drop in the prevalence from 4.5% to around between 1 and 2.5% over the last 16 years. Now, TB cases in general in our hospital, these are adult cases. In our hospital, we as ID medicine department have 3 clinics. 2 are led by ID, infectious disease, and 1 led by our colleagues in respirology. It's every Monday. Any specialty can refer to us. We can see their patients. We usually see latent TB and active TB patients. The infectious disease division, we see the extrapulmonary TB, while our colleagues in pulmo see the the pulmonary TB patients. As you can see, there was a decrease in cases in 2020, the year of the pandemic. It went down from 60 cases to 41 cases. And this is what we're seeing also in the world. And most probably it's because of the lockdown. Patients are not coming to the hospital. And we estimate more cases to be seen in 2021 because things are opening up back again. So comparing TB to COVID, okay. In 2019, we had 10 million cases of TB, while in the year of pandemic, we had 120 million cases of COVID-19. But only around 30% of these cases needed health attention, while all TB patients need health attention at the end. And the number of deaths were around 1,400,000 in TB, while it was 2,500,000. Taking into percentage, you see TB is still much more killer than COVID-19. And all patients need medical attention if they have TB. So this is the Stop TB Partnership Initiative. They estimate that we are now 8 to 12 years behind the target in treating or in tackling TB endemic. And this is all because of the COVID-19 issue. So this graph actually tells you about from 9 different countries, the biggest countries in Asia where cases are reported for TB, and they make up to 60% of the world TB burden. You see there is a 23% reduction in reporting of TB cases. And this is not a good sign. This means we are losing the follow-up or seeing new patients around 1 million cases in these areas. When you lose 1 million cases of TB do not come into the system, that means other millions will become infected with TB, and this is the catastrophe we will see in the future, or in the near future. This is from the global. These graphs are from the global TB report done by WHO. This is the first 6 months of 2020. You see there is also decreased reporting in other countries. These are the 4 biggest TB burden countries in the world: India, Indonesia, Philippines, and South Africa. And all have shown decreased reporting. This is also worrying because it means that many patients are not going into the system. And if you lose patients not going into the system, it means new cases outside the system and increase in transmission. This is also from India. So India, if you can see in the middle, when the lockdown happened in India, there was a decrease in the number of reporting in India after the lockdown. And after things started to ease, the number of cases are going up. And In India alone, there are around 1 million people who have lost follow-up or are not going into the system because of the lockdown. So it's a tsunami, and we don't know what will happen after this tsunami to TB. We know climate change affects TB, recession and poverty affects TB, health care disruption affects TB, and now COVID is an extra thing on the health system. After this tsunami, I think things will look very bad if we don't take actions now. So the impact of TB, of COVID on TB, we have logistic issues, labs are infection control issues, and manpower. And labs are not focusing on TB. Most of the manpower is going out of TB. They're concerned about COVID-19, and like embeds in the hospitals and isolation rooms are going for COVID instead of TB patients. And this is all affecting the TB care. And individual-wise, patients with TB, or either we can classify them into all TB, latent TB, or have a co-infection with TB. We still don't really know and understand what happens to patients if they have COVID and TB together. We know, like in all TB infection people, especially those with pulmonary TB, they have bad lungs. Bad lungs with an extra COVID infection on them means death. Latent TB is a state of, yes, people are asymptomatic. Yes, people don't transmit the infection, but getting COVID on top of latent TB may be also a catastrophic, because we know in the patients in latent TB, they are in chronic inflammation. Their immune system is continuously working. And we don't really know what exactly will happen. Is it something that we're going to be protective for them, or is it going to be devastating for the patient? Co-infection, it's definitely a bad thing to have TB and COVID at the same time. The immune system is going to be confused, because the way the immune system responds to TB is different from SARS-CoV-2. SARS-CoV-2 is more of a humoral type of immunity response, while in TB, it's more of a T-cell response. Patients with HIV is another issue. We already know patients who have HIV and COVID, they do as the general population. But what about if they have like TB pneumonia, an extra to COVID pneumonia? What will happen to them? It's still not clear, and we don't really have evidence about it. Drug resistance TB, especially in the areas where I just showed you, in Russia and in China, taking these medications that have very bad side effects may affect the outcome, in addition to getting COVID-19 pneumonia. Funding is actually the most important part in tackling TB. I will show you in the next few slides why we are low in, or why we have problems with manpower in diagnostics, in treatments, and immunization, because we don't really have funding for TB. People are not interested to invest in TB because it's the rich people don't have this disease. And let me show you here before going there. So in diagnostics, as we just mentioned, we have latent TB and active TB. Latent TB is diagnosed by a PBD test or the quantiferon test. And in diagnosing active TB, we have the cultures, we have the microscopy, and we have the PCR. In regards to the PCR part, we know that in low-income countries, they are more using this cartridge, this Gene Expert cartridge for COVID instead of TB, because they don't have the facilities to do the regular PCR, or they don't have the money to do both tests together. In India now, there is an initiative by the WHO for every patient to be screened for both TB and COVID-19. Going into research, like I just went into the Medline, looking into if we had randomized trials in 2020, we had 13 randomized trials in Mycobacterium tuberculosis. None of them really changed practice. So you can see the focus of the world now is in COVID-19. We have now more than 60 million published research in COVID-19, and we are losing this part to COVID-19 instead of going to more research in Mycobacterium tuberculosis. So this is one, and when we go back to latent TB, so latent TB is meaning you're infected with TB, but you don't have symptoms and you don't transmit the infection. We usually treat them with either rifampicin or INH. The current CDC guidelines updated last year recommend now rifampicin as the first line management, 4 months. It's less hepatotoxic than the 6 to 9 months regimen for INH. In 2019, a randomized trial was done for a 1 month regimen. So of rifampicin plus isoniazid to prevent HIV-related tuberculosis with a positive outcome. And I hope in the near future, we also use it for the general population in addition to HIV. The other thing is the treatment. So for the last 50 years, we are treating TB the same way. Like I'm talking about drug susceptible TB with rifampicin, isoniazid, pyrazinamide, and ethambutol for at least 6 months, depending on the type of TB. We don't really have new regimens, and this is because people are not looking for new regimens that have less side effect and shorter in duration. We had a trial, a phase 2b trial published in Lancet, that was also in 2019, with a new regimen, a shorter duration, which had also a positive outcome, but we're still waiting for the phase 3 of the trial. This is actually not published, it was reported yesterday, a trial of multi-drug resistant TB treatment. We usually treat multiple drug TB for 20 months and more with toxic medication. Now a new regimen for 6 months has been investigated by a new trial that is going to be published in the near future. If you can see, in regards to vaccination, we have only one vaccine called the BCG vaccine, and it was introduced in 1921, 100 years back. Today, this year is the 100-year anniversary for this vaccine. This vaccine is helpful for children. It's given during childbirth, and its efficacy is very low. It wanes with time. It's only effective in the first 10 to 15 years, and after that, you lose its effect. It loses its effect. We need new vaccines. The irony is that the BCG vaccine has been studied for COVID pneumonia in around 25 trials. The last trial we had for a new vaccine for TB was in 2018. It's still not approved because it was a phase 2 trial. It's planned for a phase 3 trial in 2023 or 24 if the COVID pandemic goes away. Last year, the United States invested around $10 billion in COVID-19 vaccines. While if you look into how much was invested in TB vaccine, it was around 183 million over the last 15 years. So you can see why companies are not interested in TB. Now, how to tackle TB? Ending TB needs measures, okay? And measures, this is called the Swiss cheese model. Because there are many gaps in everything, you have to take several measures to cover everything. So we need social, personal, and person-centric health system interventions to tackle TB. In regards to social, people have to understand TB. They have to be vaccinated. We need new vaccines for TB. We need to tackle poverty. We need public education, as I just mentioned. In regards to the personal part, people who have TB or suspect TB have to go directly into the health system. Any delay in going into the health system means more transmission of the disease in the community. So early care seeking of TB, face mask and cough etiquette, screening for infection and diseases. So there are certain groups. We know now around 2 billion people in the world are infected with TB. We cannot treat all of them, and I don't think it's wise to treat all of them. We know there are high-risk people because the limitation we have in diagnostics in latent TB, if it's positive, it doesn't mean that you're going to progress from latent to active TB. So we need better diagnostics, and we need to screen people who are at high risk for progressing from latent to active TB. The other thing is TB preventive therapy. So any patient who has high risk, like healthcare workers, people in incarceration facilities, people on immunosuppressive medication, transplant patients, hematology oncology patients, rheumatology patients on biologics need to be targeted for TB preventive. Quality of care, not only diagnosing TB, following up patients with TB, making sure they have good nutrition, managing their comorbidities, making sure infection control measures are taken very well in the hospitals. Now, in conclusion, tuberculosis is still the #1 killer in infectious disease. Once the COVID-19 tsunami ends, a darker picture, unfortunately, will appear for TB. We must put more funds in dealing with TB in parts of diagnostics, infection control, public health, in managing people, and in also vaccination. Thank you so much.
Thank you very much, Dr. Mohammed, for your excellent, informative talk. And now I will open the floor for discussions or for questions. If anybody has a question, just raise your hand. I will unmute you, please.
Assalamu alaikum, everyone. Thank you, Dr. Saeed, for a very nice and difficult topics nowadays in this pandemic. Now, I have two questions. One is what was the measures taken during the COVID lockdown regarding the patient on anti-tuberculosis? Because we face some problems that they don't follow up in the clinic because of the lockdown, of course, as we all know. And some of them, sometimes they call me that they don't have medication. So any measures were taken to try to solve this issue? The second thing is regarding the tocilizumab. As we all know that it may provoke the latent tuberculosis issue. And did you come across any study that reporting flare-up of tuberculosis, latent tuberculosis in patients received tocilizumab in COVID, because they are only receiving 2 doses, as we all know? Thank you.
Thank you, Dr. Ahmed. Excellent questions. The first question regards, we had difficulties in following up patients with either latent or active TB. Personally, I had several patients who couldn't get their medication. They were living outside Riyadh or even Riyadh. And because during the closure, we had to call our patients. Some of them, we didn't have their numbers. And some of them, even we had the numbers, they didn't answer us. And they popped up to our clinics afterwards, like missing their medication. I think in the future, we should look into this and make sure this doesn't happen back again. In regarding to tocilizumab, I'm actually collecting the data about tocilizumab. Number one, it looks like the incidence of the incidence of latent TB or the prevalence of latent TB in our community is very low, because most of the patients we got across by screening them with the quantiferon are negative. This is number one. Number two, as you said, it's only 2 doses. And our colleagues in rheumatology have done several studies. We actually, I went through them, and we presented them last week, I think, in our ID meeting. And it seems tocilizumab is actually a low risk for as an immunosuppression to make you progress from latent to active TB. Studies were done in Japan and other low risk areas. It didn't show any progression from, and they took tocilizumab for several doses for longer duration, as you mentioned. None of them actually reactivated. So I think we're gonna change our policy in regards to screen everyone for quantiferon if they're in COVID patients when they take tocilizumab.
Thank you, Dr. Mohammed. Dr. Mohammed Mursi. تفضل.
Thank you, Dr. Mohammed, for the nice talk. Can you hear me?
Yes, I can hear you.
Yes, I just have a question regarding the COVID vaccine. Is there any problem to receive the COVID vaccine while the patient is on active treatment of the active pulmonary TB right now?
So thank you, Dr. Mohammed. So in regards, if he's in the acute illness, I would not give him the vaccine. Basically because during the acute illness, the immune system is basically in a mess, okay? And it's not the right time to give the vaccine. It's not contraindicated, but I don't think it's going to be effective. So once he's been started on treatment for several weeks and he's out of the acute illness, yes, then I will highly recommend for the patient to take the vaccine, since we don't want him to get COVID in addition to TB, especially pulmonary TB.
Mm-hmm. And does it differ if the patient does have, for example, any underlying problem like a retroviral disease or hematopoietic stem cell transplant or something like this?
So like in immunocompromised population, you have to take it in an individualized manner. Every patient is different from another. You have to know what medication he's on, how is his immunostatus of the patient. So it's not a yes and no answer over here.
Okay, thank you.
Any other questions? Dr. Mohammed, can I ask a question?
Yes, go ahead, please.
Okay. We know that the challenge threatening the diagnosis of TB is the overlap between the symptoms between the two diseases, the COVID-19 and the TB. But did we come across a co-infection between TB and COVID-19 in our hospital? I mean, in our practice, in our hospital?
Personally, me, no. But I think I've heard one of the pulmonary colleagues mentioning they had a patient who had COVID and TB. But I'm not really sure. But personally, me and my colleagues in ID, we didn't face it until now.
Thank you very much.
Maybe Dr. Ahmed can, if he's around, still around, if they have seen a TB and a pulmonary TB and.
You mean pulmonary TB and COVID, right?
And COVID, yes.
I'm not sure, wallahi, Dr. Saeed. I think there was one patient but he was in the continuation phase with COVID. Okay. And he had he developed, as I remember, he developed complication for the COVID, not because of the tuberculosis itself. Mm-hmm. As far as I remember, yeah. But that was the only case.
So we exactly still don't really understand. Could he be by itself be protective against COVID, and not something adding bad on top of COVID? There are reported cases in Italy and in India about COVID and TB, but it's still not really published. It's only letters to the journals. So we still don't really have data about that.
Yeah, definitely. I think it still will come. I think the problem will be is just the sequelae because I mean, we have a patient nowadays. He's a COVID positive, but there was a history which is unknown, not clear, that he had tuberculosis in the past. And this was only documented that when in the report of the CT, they're suspecting fibrosis, apical fibrosis, which is we are still looking into, did he has a tuberculosis in the past or not? So that's the thing. We don't know how to deal with the patient yet. We are most probably are going to administer tocilizumab, but as you mentioned, in such patient, I have to just give him prophylactic anti-TB.
Okay, so in regards to our experience here in Prince Sultan, we have around 300 patients since 2017 who were diagnosed with TB, either pulmonary or extrapulmonary TB. I'm working with two of the medical residents. We're actually phone interviewing each patient of who's alive for asking them if they had encountered COVID during this year or not, and did they need hospital admission or not. So we'll see at the end what will go on, and we will share the data with you guys, inshallah.
Thank you very much.
Thank you very much, Dr. Ahmed and Dr. Mohammed. We have a question from Ms. Rada.
Yes, hello, can you hear me?
Yes.
Yes.
Yeah, okay. So my question is there, and if any, what support is being given to foreigners that are living in Saudi that are having any kind of TB? You know, like not necessarily pulmonary TB. Is there any support that is being given in our hospital to these individuals who may not be able to afford treatment in a private hospital?
So TB is a communicable disease, and it's free of charge in treating here in Saudi Arabia. It's like COVID-19. If you have COVID-19, whether you're a Saudi or not Saudi, you get full care for free. TB is the same thing.
So even if the TB is not in the pulmonary side, they will still get support?
You will still get treatment, yes.
Oh, okay, that's brilliant. Thank you.
Dr. Mohammed, I have a question regarding not TB, COVID, TB during the Hajj. I mean, as we all know, a lot of patients come from different parts of the world, including patients we don't know that with MDR or XDR. Is there any way you came across that you screen, or what you do? I mean, because if you have a patient with such a thing in during the Hajj, it would be a disaster. I don't know if there's any measures taken to avoid this, or what to do.
So any patient who comes from for al-Hajj should have a health certificate, okay, including immunization, and I'm not really sure if they do TB screening for them. But yes, you're right. It will be wise they do TB screening before they come to Saudi Arabia.
Thank you.
If someone else knows, they can tell. Dr. Amal, do you know about screening for TB before coming to Hajj?
No, actually, I don't think.
I came across one patient. I have a friend who's working in a military hospital in Medina, and they had a patient with XDR. Unfortunately, the problem was he came to Hajj and he was ill in their hospital, and they didn't know what to do, because to send him back to his country, unless I think you have an isolated airplane with a private jet to get to send. So it was really very difficult the next XDR to have him during the Hajj. So that's why this question, yeah.
I think it's a serious issue, since even these people who come to Hajj, they stay usually more than 10 days in Saudi Arabia. So I think it's wise they should be screened for TB.
The time is over. More questions? If there are no more questions,
I think Dr. Nazik has a question or has a comment.
sure.
Thank you very much, Mohammed. Very nice and updated talk. As you said, that there is a lot of challenges we are facing with pulmonary TB in the COVID era. My concerns as well, always, whenever we have any patient with pulmonary infiltrates, COVID negative, we should think always of other causes, especially like we have very few cases that we encountered during the period that the patients, several times COVID, and tends to be TB. So very important to wise, our mind while we're thinking about pulmonary infiltrates in the COVID era. Another concern, Mohammed, regarding the DOT therapy during the pandemic and lockdown. Do you think that we should implement like a direct observed therapy nurse that can make sure our patients are receiving their treatment in the lockdown time and in the continual phase now?
Hi,
This
how are you? Just watching. Oh, I've been making. Oh,
Can you please, Rada, can you please mute yourself, please? Okay, sorry. اتفضلي نازك.
okay. So do you hear me, Mohammed?
Yes. So in regards to TB, yes, you're right. You need high index of suspicion, and usually TB patients shop around. I'm talking about the pre-endemic era. They shop around hospitals, looking for what's going on with them. They usually are symptomatic for months or less or more before someone who thinks about TB and picks up TB. Like in the United States, a new report was published yesterday in The Lancet, like in a mean of 21 days, every patient needed to be investigated before they reach a diagnosis of TB, which is a long period, especially for pulmonary TB. Regards to the DOT therapy, I think we didn't practice it pre-pandemic. So I don't know if during the pandemic it's gonna be achievable.
Right. Thank you, Mohammed.
No worries.
Mohammed, I think you should start a project that review all patients on anti-tuberculosis since the lockdown, to review one by one.
Yeah, we actually are doing that.
Okay, good. Thank you.
If there are no more questions, I would like to conclude by saying we have to work hard in order to mitigate consequences of COVID-19 on TB by strengthening the TB control strategies, increasing community awareness of symptoms of TB, ensuring continuity of treatment and care for all patients with TB. Thanks for all and have a nice day.
Thank you, Dr.
Thank you. Thank you very much.